So continuing forward with our informative dialogues, let's move forward into our next session. So here we will discuss one of the most pressing issues facing the healthcare industry, the shortage of skilled and dedicated nurses. With the increasing demand for healthcare services and an aging population, we need to find solutions that can address this workforce crisis. So please put your hands together for our moderator, Marcia Donziger, founder and CEO of Marcia Donziger Consulting, and our panelists, Sue E. Goodin, CEO of ResilienceONE, Michelle DeStefano, MPA RN, CEO and founder of SOAR Career Coaching for Professional Women, Allison Morin, MSN RN, Vice President, Nursing Informatics at symplr, and Dr. Neeta, Nagra, ED, registered psychiatric nurse, founder and CEO of Fit to Be Strong Leader. They will be sharing their insights on the topic, addressing the nursing workforce crisis, solutions and interventions. Thank you.
Thank you. I am so excited to be moderating a panel of esteemed colleagues here. We've got 3 nurses and 1 exercise physiologist, and you'll learn about them in a moment. But first, I'll introduce myself. My name is Marcia Donziger. I am a coach and consultant helping healthcare companies build healthy, empowering, and inclusive cultures to address the problem of burnout. And my first foray into healthcare was as a cancer patient. At the age of 27, I was diagnosed with ovarian cancer, and it was treated with an emergency hysterectomy, followed by 6 months of chemotherapy. And through that experience, I got to really see how nurses do what they do. I was able to experience so much compassion, empathy, and kindness. And I believe that nurses really provide that as medication. It's that emotional connection that they make with you while you're going through the hardest time of your life. And so for that, I appreciate nurses so much. From my experience with cancer, I knew the pain and isolation and anxiety that comes with a life-threatening illness. And so a few years later, I founded a nonprofit organization called My Lifeline Cancer Foundation. And this organization had a vision to transform the cancer experience through community and connection. And so I led that organization for about 10 years, and then we merged into a larger global nonprofit called Cancer Support Community, where I served as their vice president of digital strategy initially. And then after the pandemic hit, due to skyrocketing burnout and stress and overwhelm of our staff, I became the chief culture officer there and developed a model that I called Culture Cares. And this is a model that can help provide a structure and a process for administrators to really think differently about the employee experience, the staff experience for all healthcare providers, and how are they being treated as the caregivers of our society. And CARES is an acronym for commitment, appreciation, respect, engagement, and safety. And I believe that if you really delve into those values, that you will provide healthcare workers with the best environment in which they can take care of patients. And that's really my passion, and I'm happy to be here.
Thank you, Marcia. My name is Michelle DeStefano, and I am the CEO and founder of SOAR Career Coaching for Professional Healthcare Executives. I have had over 30 plus years of experience in progressive nursing leadership positions. I call myself from bedside RN to boardroom up to chief nursing officer and now beyond. After I left my chief nursing officer position due to a involuntary disruption that happened to me, I looked within myself and I wanted to provide my skills and talents across larger organizations, across more organizations all across the United States. So I became a healthcare consultant, growing cardiovascular programs all across the United States. And I kept my sight on one day opening and having my own company and being an entrepreneur, which I've just started about 2 years ago. What my company does is that I help healthcare leaders, healthcare executives find their voice again, find their passion. I'm an executive coach, and I work with these healthcare leaders in first and foremost starting the SOAR model. We start with doing a scan phase of their strengths, their talents, helping them articulate their value proposition to their current organization. And then I work with them on scanning their internal environment or an external environment if they plan to do a career pivot to make sure that they are aligned with their values. I then work with taking their challenges and moving them to opportunities, which is the O of SOAR. And this is where I really help them with my executive coaching skill set and getting them back on track and having them find their voice. Then we create action plans, and then we review results. My results working with these wonderful women in the healthcare industry that I've had a 97% success rate in having them either get advancements in their current organizations or leave their organizations for advancement, or actually helping them career pivot and possibly starting their own business or doing something else that's in passion to them. So due to my story and what had happened to me, I really wanted to give back to my colleagues, and what I tell everyone is I will be there to watch you soar.
Thank you, Michelle. Hi, everyone. I am Neeta Nagra. I am currently the founder of my company called Fit to Be Strong Leader. In addition to that, I'm also a registered psychiatric nurse. My background, I have over 17 years working in mental health. I have a Bachelor of Science and a Master's in Mental Health Nursing, and I also have a Doctor of Education, which I specialized in leadership. And so over the years, I've progressively worked in various different positions, both working as a floor nurse and working as a registered psychiatric nurse on the floor. In addition to that, working as an educator and then also in various leadership positions. And that's what really led me to wanting to open up my own leadership consultancy. I find that there's quite a few gaps when I look at leadership in healthcare. Specifically that not necessarily everyone has the right competencies needed to be a leader, and so definitely having the potential. So it's important to help individuals develop their competencies to be effective leaders so that they can lead others, and we'll kind of delve into that and specifically in terms of the nursing workforce crisis. I also currently am the Director for Professional Practice for Forensic Psychiatric Services. So what I do is I look at the various competencies that are required for both nursing and allied health professionals, and I determine the competency gaps, help identify what education is needed for individuals to build those competencies, and then evaluate if those competencies have been met. I am also a faculty member for a psychiatric nursing program, so I'm also well versed in the education field as well. And I'll just pass it over to my colleague Sue.
Thank you, Neeta. My name is Sue Goodin, founder of ResilienceONE. I would like to ask you, how many of you guys are in hospitals or connected to hospitals? So I started out as an exercise physiologist in the field of healthcare, ended up in a hospital. I don't know why, but I did. And have since then, all these years, have stayed in healthcare only because I really felt like I could disrupt healthcare. So I've really spent 20 years disrupting healthcare, trying to improve health and wellness, and merging them so that we really have a system, an organization, a field of health that's health and wellness. It's integrated. It's all under one roof. So you can do both things under one roof. Wouldn't it be nice to have a hospital where you had massage or acupuncture or health coaching, but you also had access to all the traditional medicine too? So I think it's really important. Over the last 10 years, we have been working with 4 different hospitals. So we've overseen 5,000 employees, nurses, physicians, healthcare workers, and really we were asked to design a wellness program. So my background being a typical wellness person was, you put a fitness center together, look at nutrition, you do these things. Well, that's not what the employees wanted. So after, I'd say 60% of the nurses and the the team said, no, we want a place where we can relax, we want massage, we want to regroup during the day, and so we created wellness lounges. So we created 4 lounges in 4 different hospitals as the central point for employees to go to regroup, regain. They are staffed by board-certified health coaches, so they were able to go in and talk to somebody. And during COVID, we were the hands-on employee assistance program. We took care of all of those employees. They were so excited that we were there. We were there for them. And so it really showed me that how it's changed. Employee assistance programs have changed. They're not the same. And so, again, I'm here, I'm disrupting healthcare, and I'm going to continue to do that.
Hi, my name's Morin. I'm Vice President of Nursing Informatics at symplr. symplr is a healthcare operations company. We fill all the space between your ERP and your EMR, lots of things in there. My background is I'm a pediatric critical care nurse. I've had the pleasure of working at the #1 and #2 pediatric organizations in the country. I left the bedside after about 5 years because there was this promise of a technology called an electronic medical record, and they needed a super user. So I stepped away from the bedside and taught my colleagues how to use the technology, and really saw what I thought at the time was the promise of a technology that was going to make nurses' lives better. 20 years later, I still believe it. We just have a little bit of work to do to get there. I spend the majority of my time in organizations working on, and we'll talk about it a little bit more when we get to the technology portion, but working with healthcare organizations on how to optimize their workforce management solutions. It's important to keep in mind that the nurse that's sitting at the bedside had to do a lot of things to get to that point, that shift that day. So how do we make sure that technology meets them where they are and where they want to be, and makes, there's a lot of literature out there about flexibility and making sure, with the staff that we have, we keep them happy, we keep them in the organization, and we support them in the best way we can and allow them to come to work when they want to come to work, and making sure that we can get those nurses who are looking for other opportunities in the door faster. So technology can support all of those and then some, but we'll talk about that a little more later.
Thank you, everyone. We're so happy that you're here to share your passion and your knowledge and your healthcare disruption ideas with us. Michelle, let's get started with you. We want to start laying the groundwork with some data and trends that are affecting our nursing workforce.
So I'm going to try to be very positive with the data, and I'll say it with a smile, but the data is not very positive right now for the nursing workforce crisis. I've been participating in a collaborative, and with Incredible Health, I've been on a lot of their webinars listening to their chief nursing officers discuss some of the great innovations that they are doing for this nursing workforce crisis. And I'm here to report out on some of the findings. And then I am going to go into some 2 innovative solutions that you can probably take home or think about immediately. But for the nursing workforce, what we found is the pandemic really did exacerbate what was happening in organizations across everywhere where we practice, particularly in the acute healthcare setting. And so we always had these issues in healthcare and finding the right number of staff at the right time and flexing staff. However, this was this exacerbation that happened with the pandemic. And what we found in this time that the study came out, 4,000 nurses were surveyed that were working with Incredible Health. Incredible Health is a staffing outsource company that helps recruit nurses, not executives. And so in this white paper, what they found during the pandemic was that hospitals were now, the increase in travelers to the organizations had gone up to 77%. Now, I was a chief nursing officer, and I had about 20+% of travelers in my organizations, but can you imagine, all across the board, 77% were travelers. What happened with the increase in travelers coming into the organizations was that the permanent staff were feeling that the culture of their units was declining, because these travelers are assigned maybe 12 weeks, maybe 22 weeks, whatever their contract is. And they're very much devoted to the profession of nursing, these nurses, but they weren't really committed to the organization or to the unit. And with that occurring, also they started, the permanent nurses were starting to discuss the decrease in quality of care. A traveler nurse may get about 3 to 5 days orientation, whereas a new nurse coming into, a permanent nurse coming into your organization gets at least a month or more, but if you're a GN residency, you'll get several months. So with that type of decrease in experience of the culture and decrease in quality of care perceptions, what started coming from this, because travelers were working alongside our permanent staff, making 2 to 3 times more money, and then the constant churn of orienting these travelers, burnout became amok with these nurses that were permanent staff, and now pay became a prominent reason why nurses were leaving the bedside, because they were watching their traveler friends, right, making all the money. And so this then perpetuated the whole complexity of the pay initiatives and why nurses were leaving the bedside, all right? Another daunting statistic is that during the COVID pandemic, what we found was that 65% of nurses actually stated that they were verbally or physically abused. 65% verbally or physically abused by patients or patients' families. And now we have seen this before the pandemic, okay? There's a lot of reasons why sometimes this happens, with everyone's emotions running amok and, you know, not having a volatile situation. However, they talked about the nurses, the policies that were put in place. We were thinking on our feet as to the policies and procedures of actually having the visitations and we were really doing a great job of keeping visitors out of the hospital as loved ones. And so this created a lot of volatility. And also, these nurses also reported that they were also being discriminated sometimes by their own supervisors and colleagues. So the other reasons then for nurses leaving was advancement, that when a new nurse comes into an organization, there wasn't anyone talking to them about where they saw themselves in 3 years. Is that all there is? There was no pathways in place, such as, do you want a clinical pathway, do you want an administrative pathway, and working towards getting them to meet that goal. And then there was things such as relocation, and once again, the pay burnout and leaving the bedside to do other types of nursing roles, such as, you know, employee health, occupational health, becoming clinical nurse leaders, but everyone was trying to escape this bedside, whereas where we really need in the acute care setting these are nurses that are much needed in the hospital setting. So that's the painting picture. I just got a text from Incredible Health. They're doing an executive oversight. A year later, they talk now to executives. It doesn't look much better. But now I'm going to try to be very positive and talk about some things that we can do, particularly if you're a leader. And this is what I actually do within my SOAR model. I help these leaders become resilient and think out of the box, have them untap their potential and what they can do to be creative. So as a chief nursing officer and having the utmost use of travelers, one of my goals was to decrease travelers. It's not that I didn't like these nurses, respected them, but I needed them out of my organization. They were costing me a lot of money. The culture I needed to keep on changing up. I needed to worry about all the quality metrics, UTIs, CLABSI, you know, everything else that was unimaginable that was under my reign. So I got with my team and I said, how can we work with HR to be extremely creative about this? And I watched my recruitment and everything else, brought new nurses in and knew exactly when travelers would be eliminated from my organization. And what we did was we decided to look at the cream of the crop travelers, okay? And we sent them letters from the chief nursing officer to the director to the unit level manager, and we basically said, Uncle Sam wants you. We like what we're seeing. Let's talk to you about the culture here. Because sometimes travelers are escaping something and they're traveling for a little while, but they eventually want a permanent home somewhere. They're looking at different states, climate, whatever it is. And so we did this, and it was so powerful that we actually recruited traveler nurses to our staff. We actually talked about our culture and the changes that they wanted to see with our staff and did a lot of stay interviews with them. But we actually, within 3 months, decreased travelers in our organization by 20%. And these nurses became our next charge nurses. They became our next leaders. So that was something that we worked with HR. We put places and plans together. And I also want to talk then also what else we can do to think out of the box about the use of technology. And I want to do this with a story. I worked with a company called Cetera that is a monitoring. It's a non-invasive monitoring that does blood pressure monitoring, O2 sats, and it's actually like a telemetry station. But what it does is does continuous vital sign monitoring that you actually get stats and trends for your patient. So I wanted this on one of our units, but what I wanted with the use of technology was what was this technology going to do to increase the hours that nurses could have at the bedside with their patients. Because what we did is we did time stamps and time studies of how much time it was to put on the blood pressure cuff, find the right blood pressure cuff, a small one, a large one, whatever it was, right? Surgical units every 15 minutes post-procedure. And so we did a timestamp, and we saw the amount of time it took to have this all happen. And then we worked on the workflow processes, working with Cetera. And what we found after this outcome with technology was that we gained 4 hours a day back to the nurses to be at the bedside, okay? Not running around doing but being there with the patients, okay, being there where they were supposed to be. And then we also found for patient outcomes that it decreased bounce backs to the ICU because we had so much more information and we knew what was happening, every second with the vital sign monitoring, and it also helped with our failure to rescue. So this is something that I really encourage everyone to start thinking about. If you are in these hospital settings, what can you do to leverage technology? What can you do to look and get your permanent staff back in? But there's still, even though this data looks a little grim right now, there's still a lot we can do as leaders to help this nursing workforce today and now. Thank you.
Thank you, Michelle. So just building off of what Michelle had said, and actually some of the other talks from earlier today, something that I have witnessed and experienced in healthcare is often people are put into leadership positions based off of being a good nurse or a good doctor or a good social worker, not necessarily based off of their leadership skills. And as we know, having leadership skills is a lot different. So the first thing that's required in order to be an effective leader is to be comfortable with change. Just the talk we had right before was, I believe, Brian, you were talking about healthcare being behind. And that's because as we have all this data coming, what are we doing with that data? We're not going to be able to do anything if the people that are leading healthcare don't have the skills to be open to looking at making quick changes or effective changes. And so that comes in hand with being able to have conflict resolution skills. It's vital when we're dealing with change to be comfortable with conflict, and not only being comfortable, but also being able to manage it in a professional manner and equip others to be able to move along. And so, so those are a couple of big gaps that I have witnessed working in healthcare, which is why I find that there's a lot of challenges happening, because a lot of the nurses, they're experiencing a lot of various different factors. So some of those are, the challenges that happen with healthcare. Nurses are being abused, not only from patients, but also there's a lot of horizontal violence that occurs within healthcare. The other issue that we're facing is we're working with 4 different generations, and each generation has different values. So it's really important that the leaders understand what the values are that each generation brings and how you can leverage those strengths for everyone to work together effectively. And so I think there's various different factors involved. And then the last factor I just want to touch up on is, I'm just curious, how many people here are clinical staff? Okay, great. How many of you have heard of compassion fatigue? How many of you have experienced compassion fatigue? Yeah, I'd say probably everyone that works in healthcare has probably experienced compassion fatigue, but I think that's something that leadership will often miss, is understanding that everyone that works in healthcare is prone to, and so sorry, for those that don't work in healthcare, compassion fatigue is essentially the cost of caring. So it's a combination of secondary traumatic stress along with burnout, which leads to individuals eventually starting to feel numb or just kind of checking out of, I guess, in their job duties, and eventually the profession. And so in order to effectively deal with all of these various factors that we're constantly or currently facing in healthcare, leadership needs to be aware and have those skills to support staff in doing that. And I think one of those big things, which is what we're going to be focusing on today, is supporting staff in building resiliency and also self-care. So I'll pass it on to my colleague here to speak more about that.
How many of you took a course when you were in school on resilience? How many of you have really understand what it takes to be a resilient person? So what I'm seeing, great, good for you, because a lot of the nurses out there today and a lot of the staff are not. And so like Neeta was saying that like our chaplain says to new hires in the nursing field is like, if you don't have some skills, some tools that will help you through the day, you're not going to survive. And so a lot of them are getting burned out and they're leaving the profession, which is really sad. So one of the things that we've done as an organization is that we have partnered with several organizations to help us really look at the whole person, physically, mentally, emotionally, and financially, so that we could help give them some tools that allowed them to feel better about their job, where they were happier and healthier to go to work every day.
You may keep going. Pass it back to us. Yeah. Marcia, sorry. I'm just sitting here holding my own.
Thank you. Let's talk about the work culture and work environment. I was going to ask specifically, Sue, what data-driven models have you seen that can make a meaningful difference in the daily lives of nurses?
When we started opening the lounges, and this was like 2018, something like that, we were asking employees what they wanted in the lounge. And like I said, health coaching, massage, various different things. We had aromatherapy. We had a lot of education programs going on then. But what we found is like 500 out of 1,800 employees in one of the lounges, 500 of them came every month to visit the lounge. And this might be people in food service, or they were in environmental services that would have never walked into a fitness center. So it was a real eye-opener to us as to those populations were not being served. And then what we also learned is by going to the floors and working with the nurses directly, and then incorporating a digital platform, we were able to see that we could really manage or at least support them on a daily basis. And I'm truly convinced that digital platforms are great, but you do need the human touch. This is what we're always missing, is the human experience, the human interaction. So if you combine those two, I think the data will show you. And one of the data points we got from the employees is, I want one-on-one support.
Thanks, Sue. Allie, let's talk about technology and how it can positively impact us. What role does technology play in addressing the issues facing nurses today?
Sure. So I'm going to kind of ground us with a little bit of data. So in 2022, there was a longitudinal study done by the American Organization of Nurse Leaders, and it identified that 45% of nurse managers are looking to leave their position. Additionally, of those nurse managers, they recognize that they spend 60 to 80% of their 12-hour shift as a nurse manager working on filling shifts, working on schedules, working on the current schedule, the next schedule, this shift that's coming up in 2 hours that I don't have enough nurses for. So let's think about what those nurse managers could do with 60% of their time back. How do we give them time back? How do we let them spend time, to Michelle's point, talking to their nurses about what their career aspirations are? Where do they want to go? Are they happy where they are? How can we keep them happy? What do we need to do to give them options to go elsewhere if they want to go elsewhere, and support them? So technology, from my perspective, really lives in a supportive perspective. It needs to be able to support those nurse managers, support those chief nursing officers as they're looking at productivity, and make sure that we can reduce the traveler spend. So how do we do that? You got to have, it has to be supportive of central staffing offices, new care models. There's I think, I don't want to say there was anything good that came out of COVID, but certainly, you know, the ED doc who was sitting up here before, I'm sorry, I forget your name, you know, thinking about March 2020, they opened up a triage center in a parking lot, and they had to figure out how to get nurses out there. How do those nurses, where do they come from? How do I staff that? Vaccine clinics in an NFL stadium, how do we staff that? You need to have a technological solution that allows that to be an option. And to do that, you also need to have visibility to the skills and competencies of those nurses. Where can I send nurses? If I'm staffed well here, how do I move some of those nurses and put them over there so that I no longer have to go into travel or into agency? How do you build an internal float pool, right? How do you make it so that I can move nurses? There's tons of large healthcare organizations in this country right now mobilizing internal staffing agencies so that they don't have to go outside, and they're going to put nurses, they're going to say, hey, go live in, you know, in this area 600 miles from here for the next 12 weeks because you are part of a central staffing float pool, and that's where I need you to go so that I don't have to pay for other nurses to come fill that shift. So it's really about having technology support these new models of care and have these, you know, have the ability for nurse managers to spend less time on payroll Monday. I don't know how many people, right, Michelle, how many people hated payroll Monday? They would call in sick. No, I'm just teasing, to avoid payroll Monday. You know, there's a lot of technology, and that's just in the workforce space. You know, that doesn't even get into new team-based care models. I mean, the numbers are not, I don't want to be grim, but the numbers aren't great about how many nurses we're going to have in the next 20 to 30 years. The pipeline coming in isn't being accepted into nursing schools because we don't have enough faculty. So how do we get enough faculty? That's a different conversation for a different conference, but the staff that we have to get creative about how we're going to use them. It might not be the same nurse for those 12 hours. We have to get creative about how we're going to staff the patients that we have and make sure that it's, you know, mobile first is really the concept. How do you get nurses mobily able to move? And I mean mobile applications as well as mobile. You know, get in your car and go to a different hospital because that's where you need to sit today. It's really, you know, technology, again, I'm just going to keep repeating it, needs to support new ways of delivering care. And that's, you know, we could talk about EMRs, we talked about it a little bit earlier, we could talk about machine learning. I think there's a lot of opportunities there from the perspective of staffing, you know, looking at predictive census, looking at predictive staffing, make sure that you have the opportunity to have visibility in that so that you know what you need to do in the second half of this year and you're not surprised when you get a flu surge. You know, from a that's technology is wonderful when it's used the right way. It needs to be done from an enterprise perspective as well. You can't have technology in this hospital that doesn't talk to the technology in that hospital. Again, we're gonna run out of nurses, and we got to be able to move them and be able to see who's where when, so that we can continue to have patients have improved outcomes. That's what we all went to school for, right? Is to take care of patients. I always say I don't know any nurse that went to school to spend 35% of her shift documenting in the EMR. I know docs are 52%, but nurses aren't that far behind. So we need to really use the technology we have in the best way possible.
Thank you. Technology is really key to help us find some scalable solutions to these workforce issues, and along with culture. One story that comes to mind is last summer my son needed eye surgery, and I went with him to the clinic on the morning of the procedure, and as you can imagine, we were both extremely nervous. He needed a growth removed from his eyeball. Very scary. And we were in the waiting room for an agonizing 30 minutes that felt like 30 hours, and the nurse called us back through the double doors. She took us to our bay where the nurses started hooking him up to his IV, blood pressure, temperature, everything he needed. So we were both just really focused on the procedure that day, and after the nurse finished everything she was doing so efficiently and so kindly, she turned to me and she said, "So what do you do for work?" And it was like the last thing on my mind was work, but I know I really appreciate that she was trying to distract me from the stress I was feeling at the moment. And I just gathered my thoughts and I said, I help healthcare workers feel valued, respected, and appreciated, and less burned out, stressed, and overwhelmed. And we all had our masks on at that time, and she grabbed my forearm with her blue glove, and she said, "We need that here." And it just, just from one nurse, I know that all nurses and healthcare professionals and our frontline workers are really feeling it especially after the last few years, but all along. And so I thank you for all of your, wonderful solutions that you're sharing today, especially with leadership development and managers. I'd like to give everyone on the panel a minute to talk about one quick action idea that you can offer up, or a solution that hasn't been mentioned yet. And we'll start from Michelle.
So when we talk about the unit culture, we're talking a lot about the staff nurses and what's happening, but it's also very critical at the top as well. And the turnover in executives and leaderships in organizations is pretty rampant out there. CEO turnover is 18% annually, the CEO. However, compared to the chief nursing officer, 62% of chief nursing officers turn over annually, and out of that 62%, 25% are asked to leave. And it's usually because a new CEO has come into town, they want to go in a different direction, or they're burned out. Another solution, and we were talking about this earlier, is that what we find is that there's very little leadership development for these nurse executives, from nurse manager of the unit level clear up to chief nursing officers, okay? The best clinicians get hired for the job, and then it's basically baptism by fire. I just recently surveyed on LinkedIn how many organizations were putting in developmental programs for their leaders, and it came out that it was just starting to think about it after we've just gone through this healthcare crisis, and then others were saying no, they did not. So what we really can do is think about how we want to do development in the organizations. But the programs that do have leadership development are pretty much standardized to learning the way of the organization. So they'll teach leaders how to do budgets the way they do them. They'll teach leaders how to maybe do performance appraisals and those kind of things. Where it's lacking is this whole individual coaching that's needed, where you have a coach, an executive coach, that is really working with you individually, where you can have the utmost security and relationship and building a rapport with those individuals, so that you can talk about your fears, things that you're challenged about. So I do encourage all of you to think about how those leaders are being developed in the organizations, and what we can possibly do to further that, so that we can stop the bleeding. Because once the leaders leave too, the staff gets more anxious and excited when they start seeing that even the top isn't staying.
Thank you. And just building off of what Michelle said, I find that in organizations where where leaders are given an opportunity to participate in development, so they'll attend a course. However, that's quite limited. And so, just out of curiosity, how many of you have learned about a specific exercise program here? Yep. Okay, so you've learned the theory. How many of you have gone to the gym and learned how to do an exercise? Okay, and after just doing that once, how many, if I was to ask you to do that again now, say 2 or 3 months later, would you be able to mimic that or build muscle off of that? Yeah. Okay, well, that's great. But often that's what happens. Most people are a 10-day program, they learn the theory, maybe they'll practice simulation, and that is it. However, in order for them to really develop competency, they actually need to be continuously applying it. Having continuous evaluation check-ins, so that the competency actually moves away from foundational to something that they become either an expert or intermediate or expert in. And so I think that it's, like as Michelle was saying, it's really important that it's not just giving them the opportunity, but also really investing in them to develop the competency. Because once the competency is developed, then they'll be the ones that are leading the frontline staff, nurses, other allied health professionals, to really be adopting and embodying those skills as well. And I think one of the biggest things that I find is resistance to change, which is really needed. We have all this new data coming, we have all this technology, Even me, just implementing an electronic health record in my health authority, that's really challenging because people just don't understand why they have to use standardized boxes to document where they were documenting narratively before. So we're still a long ways away, and in order for us to really help shift the pendulum in healthcare and have us current evidence-based, we really need to make sure that the resources that are helping or implementing these changes have the skills and abilities to get everyone on board so that we can continue moving forward.
And I would just like to add, listen to your employees. No matter what organization you're in, listen to your employees. Figure out what they want and what they need to be able to support their resilience and their well-being. And then a lot of times people think that putting a wellness program together is really no big deal. But strategically, you really have to look at what are your goals and objectives, and then look at the data. Look at how can you figure out how best to help support each and every one of your employees. And that also means leadership too, because a lot of times leaders will say, oh, we don't need that. And then they become really very stressed out, and then they're no support.
My parting words are be intentional and prospective about the technologies you're bringing into your organizations. I think healthcare is slow and it's reactive when it comes to technology. You know, we see data and we say, oh, we've had a spike in, falls, CODI, CLABSI, you name it. Let's go buy something that's going to help solve this problem for us. There are, I think, one statistic I remember hearing, and I'm probably going to botch the numbers, that a healthcare organization has hundreds of technology solutions in their portfolio. How many of those do you really need, and how many of those are enterprise-wide? Because just because you have a solution doesn't mean it's going to solve a problem. The right technology for the right clinician at the right time is kind of my mantra, and making sure that you have that is really going to help support those staff, reduce the burnout. Throwing a technology at it is just one more solution that somebody has to log into. Whether you have single sign-on or not, you still got to log into it, you still got to learn how to use it, you still got to know where to go find it. The retention and the adoption of those solutions is minimal if you don't have a strategy and you can explain to the staff, we're using this technology to solve X. This is the outcome we expect to get from using this new technology.
Thank you. And we have about 5 minutes left, so please come up and ask questions. What's your name?
Hi, good afternoon. I'm Dr. Julie Harrigan, Physician EHR Solutions. Thank you all very much for not only giving an amazing presentation, but for also being our very wonderful, caring nurses. So we love you. My mom's a nurse, so I have to say that too. So I'm a physician. I'm a clinician at the bedside, and specifically a hospitalist right now. And I would really love to hear your thoughts about, and I'm sorry, I wrote down my question so I wouldn't botch it. What are your thoughts on what I call nursing filler work? So, CMS, the regulatory bodies have decided that you have to do all of this meaningless charting that, at least for myself as a physician, I'll go in and I'll read that patient's chart trying to get a clue as to what's going on, what happened in the last 24 hours, how that patient's doing. And what I'm finding are things like, and I can actually quote this because I just took a picture from one of my ICU patients' EMRs, and it's charting where it says problem, safety, goal, free from accidental physical injury, outcome, progressing. But it tells me absolutely nothing about the patients. It doesn't help me clinically, it doesn't help me psychologically, emotionally, it doesn't help the patient, and nobody knows what progressing means. But somehow CMS, which I have various degrees of opinions about who makes up these rules in a closed room with no windows and never had a girlfriend, but that's my personal opinion. But, I wonder how much of that is contributing to the burnout. And so that's my first question is I'd love to get your personal opinions on that. My second question is so things like these kind of seemingly menial tasks that are causing you to not spend time at the bedside with your patient, that are causing staffing issues, that are causing backup issues, that are causing, nurses to leave the workforce because they do get burnt out. Could we be teaching other ancillary staff, MAs, other non-physically clinical folks to do some of these things that are truly not clinical, not helpful, not really improving our safety measures? I mean, if you look at the hospital systems, we haven't I mean, they're getting worse instead of better, and then contributing so much to burnout. So I appreciate your answer.
So I'll try to take, because it looks like there's two different questions that you have here, but as far as the CMS, will come into your organization and will try to shut you down. However, what you just described, I do believe that's an interpretation of what CMS wants. And so as a leader for many, many decades, it's really about having great documentation, and it's really having meaningful documentation in the charts. Now, the EHR has been mostly, check the boxes and things like that, and the narratives have gone away, so I think that that's a little skewed of where you find this information. But I would strongly suggest that there is still a narrative, and if there's not a narrative, that there is interdisciplinary rounding on the units with the physicians. You're standing next to my husband, who's a hospitalist, and so I hear this every day. But the thing is that how do we really do the handoffs, and how do we really communicate what's happening with interdisciplinary teams, and really being at the forefront and knowing what's happening. But I do think that was probably a workaround, because they weren't saying that the patient was progressing, so someone decided to put progressing in the chart. That is my personal opinion.
Yes, it's been built as an automatic.
It's been built up,
and it's a checkbox.
Yes. So it really start thinking about what is that value added in the chart, even if we do have these EHRs that have kind of taken us away. That's my opinion. The other one that you talked about, and I'll go back to technology and time at the bedside. Okay. A lot of the things that we've worked on for years is when we look at patients that need more surveillance. And so in my organization, what we did was we actually created a virtual, it was housed in the hospital, but we had surveillance of techs that were trained for patients that were on suicidal ideations and patients that were on one-to-one care or fall risk. And so we trained up these very good, CNAs, whatever, and we had them virtually where they would beam right into the nurse to say, this patient is looking agitated, this patient is doing this now. And that really kept the nursing assistant at the bedside, because that is the extender of the RN. And if you take away the nursing assistants for one-to-one care. So there's those kind of models. The other thing now with what we're trying to do with flexible shifts is that when you have, a lot of nurses want to work 4-hour shifts, or they want flexible shifts, particularly if they're burnout or if they're getting to retirement age. So thinking about where your peaks are in documentation, where your peaks are admissions, and having nurses virtually or come in for those peak times to do the documentation, to do the admission assessment, okay, so that you're not, some of these tasks that take time, which is the documentation, things like that, right? You have some support at those high peak times, but you're also keeping an engaged workforce, because these are the nurses that still want to stay employed, but you're not saying, well, if you don't work full time or if you don't work a full part time, that we'll have to let you go. So those are just some of my personal thoughts on what you talked about, and hope that answered.
That's a very thoughtful approach. Thank you.
Thank you.